teammates and as providers change. So each of us in here have our own sort of separate professional ethics codes that we're required to follow. So I see some psychiatrists in here, I see some counselors, some social workers, et cetera, nurses. We all have our own separate codes. And so it's on each of us to really understand how what are the principles of our ethical codes, to know the code to begin with, and to understand how our personal values can fall in line or maybe not fall in line with the code that you're assigned to. And so sometimes your values may not end up aligning with your profession's ethics. And so then what do? Who do you lean on? What do you lean on when you need help making that ethical decision? And then an additional tricky area is if your values don't align with the values of your fellow treatment team member. If you work on something like a multidisciplinary treatment team, what happens if everybody's got a separate viewpoint there? How do you all come to an agreement about what's the best decision to make there? And notice I didn't say what's the right decision. Sometimes it's really just about what's the best fit decision. There's several different ethical codes I could talk about this afternoon. I will end up referencing NADAC and ACA the most. NADAC is the Association for Addiction Professionals. And then ACA is the American Counseling Association. Those are the two I have to follow, so that's just what I'm going to talk about the most. I'm going to read NADAC's definition here. I think it's a good one. Ethics are generally regarded as the standards that govern the conduct of a person. Smith and Hodges define ethics as a human reflecting self-consciously on the act of being a moral being. This implies a process of self-reflection and awareness of how to behave as a moral being. Some definitions are dictated by law, individual belief systems, religion, or a mixture of all three. And so one of the aspects of this definition that can be sort of the most challenging really is that word moral, because so many things, including the laws that we abide by, including our individual belief systems and our religious viewpoints, can really alter our perception about what we believe is moral. An sort of common example of that would be abortion. And so reaching out to our ECHO community for suggestions on recent ethical dilemmas you guys have faced. Here's the dilemmas that were shared with me and or requested to kind of discuss for future guidance. So we're going to talk about confidentiality as it relates to peer recovery support specialists. We're going to talk about boundaries as it relates to inviting patients into the advocacy field. And then we're going to talk about informed consent when assessing patients' current substance use. So for each of these, I'm going to share the question that was posed to me. I'm going to review some aspects to consider regarding that dilemma. And then we're going to have a quick case example that will hopefully elicit some group discussion, thoughts and suggestions to kind of review together. So I'm terrible about seeing the chat box when I'm presenting and whether it's like people signing in or questions. If I miss any questions, I apologize. I will find them at some point, or somebody can just unmute themselves and say, Katie, stop talking, I've got a question. So in the topic of confidentiality, the question that was posed to me was whether peer recovery support specialists should sit in on treatment team meetings. And the question is because they're going to be hearing personal medical details about patients, and they had a question of whether that was okay or not. So as more of us are being blessed with the opportunity to work with peer recovery support specialists, they are a priceless resource. We're all really learning together about how to manage the dual relationships that sometimes pop up. And it gets even more interesting when you're working with a peer recovery support specialist that's also a patient in your clinic. So these questions are going to continue to come up. I'm so glad people are asking about them because it's a learning curve for all of us. So some things to consider and to remind you of, specifically in West Virginia, peer recovery support specialists are required to abide by the NADAC and NCC AP National Certified Peer Recovery Support Specialists Code of Ethics. So they do have their own code of ethics they have to abide by. That code isn't super detailed, and it is a bit broad about requirements. However, within that code, the peers are instructed to abide by their agency policies. So what that means, for example, is that your peers would follow the same HIPAA code that we all have to follow with confidentiality. And chances are when your peers started on your team, they probably had to go through, sort of a similar process with your HR, similar paperwork they would have signed when they started to work with you all. If your peers are also members of any peer recovery communities in town, like AA, for example, they are also expected to follow those confidentiality rules. Now, their rules aren't laws the same way they are for us, but they are vital to the integrity of these communities. So in a minute, when we look at a case example, we'll talk about how those don't always align. It's ultimately up to your agency how you decide to involve the peers in the treatment aspect of the program. Just to let you all know that within our agency, our decision is that the peers are an official member of the treatment team, in addition to acting as a liaison to the community. And so what that means is, in terms of informed consent, we do inform the patients ahead of time that they're going to potentially be in a group with a peer recovery support specialist. We let them know ahead of time they're a part of the treatment team, they're a part of the treatment team meeting, so they are going to be hearing information about them. We also let them know that if they happen to see those peers out at a peer recovery meeting like AA, what is said in those rooms stays confidential and is separate from what their treatment team needs to know about them. We do also, a sort of another best practice aspect to consider is we do inform the patients that if they happen to be assigned to a peer or a peer is in their group, that's going to create a dual relationship, we try really hard to move them into a different group or have a different provider. So for example, in Morgantown, some of our peers also happen to work with some of the sober living houses in town. So maybe they're like one of the managers at the recovery house. It puts the patients in a particular bind. Oftentimes the sober living homes have a very strict, if there's one relapse that's experienced, then they're asked to leave the house. And so it puts patients in a bind. If they're in a group with a peer recovery coach, they need to be honest with us about their recent use. But if they're in that group with a peer, does that gonna mean they're gonna get kicked out of their house? If they aren't honest with us because they're trying to keep information separate from their peer, does that then jeopardize their treatment with us? So we try to avoid them getting into that conflict and just have them in separate groups. So here's a case example for you. A peer recovery support specialist working in your agency sees one of your MAT patients at a meeting, and the patient discloses a relapse. This patient then does not disclose that relapse at their next clinic appointment. So what would you all do? You know what, I'll stop sharing so we can actually look at each other's faces.
Yes, please feel free to unmute, chat in, but we'd rather hear your voice.
Yeah, what would be your, does your agency kind of have guidelines on that so far? If we're looking at the ethical codes, you could sort of see this as a dilemma of you're trying to honor the confidentiality of the patient, but also honor the safety of the patient. Those of you that have peers working in your agency, what have you communicated to patients that would happen in that situation?
We only just got them, so I don't think we've actually had this issue before.
Okay.
And we don't have them for outpatient, the peers, but we do for our withdrawal management side.
So nice.
And so it's I don't know that we've ever had that, but to be honest with you, maybe I'm showing my ignorance here, but I feel like the peer would not be obligated to say anything at all. They're not the patient, and so the clinic itself will eventually, usually if someone's relapsing, eventually that kind of comes out, whether they did initially or not say something. So I feel like the peer would just maybe, encourage them on the side to be like, hey, you sure you don't want to tell them about that, but I wouldn't expect the peer to disclose that information.
Yeah. So Nikki, you are not showing your ignorance. And actually, first of all, that's what I love about this group and this ECHO model is that we're supposed to come and go, hey, I'm not really sure how to handle this. What would you all do? But in fact, you handled it right on the money. So that's that's how we instruct our peers, and that's what we tell our patients ahead of time to expect, is that for our program, the expectation is that the peer is going to keep confidential what patients are sharing with them, and especially specifically in the 12-step community or the peer recovery community, because that confidentiality is vital. And if we blow that integrity, that's not good in the long term. Exactly how you said, what we ask the peer to do is really encourage. So let's say Derek is in my group, sorry, Derek. And, Derek discloses in an AA meeting that he had a lapse, but then he didn't come to his next appointment and tell us that. When we saw him in group next, he said, yeah, guys, I got 30 days sober. We would ask that peer to reach out to Derek ahead of time, or, sort of off to the side, give him a call, see him in a meeting and say, Derek, I just want to talk through with what happened. I am keeping that information confidential, but my hope is I can work with you along the way to help you get to a place where you recognize it's in your best interest to let the team know what happened. It becomes slightly, if the peer is worried about the patient's safety, maybe based on what the patient is relapsing on, what are their current using practices, we've asked the peers to kind of reach out to the treatment team and just sort of give hypotheticals and not give any patient information, but say, here's sort of a case, this is what's happening, what's really best kind of medical practice for this patient. And at that point, they can decide if it's a patient safety issue, that's a reason to break confidentiality. But by and large, the direction is to not do that. So great job, Nikki.
This is Jennifer.
Oh, Jennifer, it's good to hear from you. Your connection's kind of going in and out.
Marbles. Oh, okay. I'm driving.
It's better if you.
So maybe I'll just listen.
Well, no, it got better wherever you just drove to. If you want to try now.
Okay. Okay. Yeah, this is so interesting to me, this topic. And in our organization, we have the peer support specialist who actually runs 3 of our closed NA meetings. And we've chosen to have him not be part of the treatment team, partially because of this dilemma. And he has actually been learning or knowing things about the patients that are disclosed either to him during an NA meeting or in other, he does transport too, that he feels obliged to keep confidential for the sake of his relationship with the patient. And yet he knows that it's important for the treatment team. And so I think it's really interesting about the dilemma it creates for the peer support specialist to be part of the treatment team where you can't contribute important or concerning information that patient, that could contribute to the patient's care. And I just think that's a little angle on it that is tricky for the peer support specialist. If they're indeed part of the if they're indeed part of the treatment team.
Yeah.
So in our organization, the peer support specialist is part of the systems team and is intimately involved in the development of the system and the procedures and protocols and that kind of thing. But as far as each daily huddle, protects them from that.
First of all, Jennifer, I hope I'm not interrupting you if you're still talking. We lost you a little on our end. First of all, I appreciate everything that you're sharing, and I'm going to summarize it because the part of it we lost, and I want to make sure that I am hearing you correctly. I really appreciate what you're sharing is, really what I've been talking about is mostly from the patient's perspective, but you're giving the peer's perspective of what what's the comfort level for them? What helps them feel safe in their role, and not put them in any kind of too awkward of positions if we're putting them on the treatment team and there's things they need to keep confidential. So that's such a great perspective to keep in mind too. Did I get that?
Yes, that's exactly my point. Thank you.
Okay.
And
Yeah.
over and out.
Yeah, no, I mean, we got most of it. It's really just the tail end that we missed. Yeah, such a great perspective. Anybody else on here that work with peers? Is that what's your experience in talking with the peers about how they feel being a part of the treatment team, how they feel about seeing these folks in treatment and out in the community?
I think as far as like Alcoholics Anonymous and Narcotics Anonymous, as the name implies, it's anonymous, and what happens there stays there.
Yes.
I think that's critically important.
Yes.
And,
Oh, so agree, Dr. Gorby. Yeah. And to absolutely agree. And to Jennifer's point, it's a great reason to make sure that your peers have really good supervision so that when they are encountering those, what do I do with this information, that they've got somebody, potentially off the treatment team that they can troubleshoot that with and sort of talk through their own feelings of discomfort that's happening as they're working with this population. So to make sure they've got great resources. Thanks, Dr. Gorby. Thanks, Jennifer, very much. Anybody else? Any additional thoughts or questions? Bill, anyone? All great ideas. Thank you. Let's see if I can appropriately share my screen when it's flip-flop. Can you guys see that?
Yeah,
Okay.
I see it fine.
When I stop sharing and resharing it, to me, sometimes that's when it gets squirrely. Okay, we're going to talk about boundaries. So another great question that was posed to me is whether it is ethical to identify past or current patients that may be open to sharing their story in a way to advocate for substance use disorder treatment and sort of to advocate for their recovery field. So I'll use us as an example. We often get requests from kind of various types of agencies that want to hear from our patients on their experiences with addiction and recovery. We've also heard from a lot of agencies and sort of outlets over the last handful of months when they're wanting to talk to our patients specifically about their telehealth experiences, because there's a potential for telehealth rulings to change. And so they're wanting to get feedback from patients on, was that feeling like good treatment for you? And so we've heard from news outlets, from nonprofit organizations trying to put together information to share with lawmakers, and we've heard from lawmakers themselves. And so the sort of question is, how do we ask patients if they want to share their story without pressuring them to do so? And so of this dilemma, aspects we want to consider would be making sure that we're reiterating to them that they absolutely have a choice. So one way we will do this is so let's say there's this outlet that is trying to gather some stories. They'll give us their content information and we'll give that to the patients so that ultimately it's on the patient if they want to reach out. We don't need to be this kind of middleman going between. We don't need them to know if we're wondering if we reached out. We sort of give them the information. It's on them if they want to follow up. It's also, they're welcome to not follow up and just pass on that. Counselors and social workers have a distinct ethical code regarding not exploiting the provider-patient relationship. I would sort of assume that's in other ethics codes, but I'll admit I didn't look. And so we would want to present them this advocacy opportunity as an option, but not that they're doing us a favor they're not doing us a favor by participating in this. And we also want to make sure we're not guilting them into helping. Here's a question I have for you all. Is it our responsibility to warn the patients of the risks of sharing their story? Do you think it's on us to warn them of some of the negative feedback that they could experience in participating in this? So, we've had patients who will share their anonymous story with news outlets when they're talking about their experience in addiction recovery. We've had folks go on camera sharing their stories. We've had, people participate in, national news articles. Do you all have any thoughts on, if we are kind of making those connections for patients, is it also on us to say, I think it's great that you're doing that for your field. I also want to warn you about some things that could pop up from that. I'm going to take your silence as a no. It's not on us. Okay. Let me scooch over to the case example. So I'm going to give you 2 cases. I want to hear from you all if you feel like they both feel like ethical options, if one feels better than the other, and if there's details that we could maybe change that would make them feel more ethical. So case example number 1 is you teach an addictions course for medical students, and you ask one of your patients to share their story to the class. You tell them that they can count the speaking engagement as one of their treatment requirements for the week. Maybe they can miss group, or, they only have to go to 3 peer recovery meetings instead of 4, or something like that. Case example number 2 is you are aware of a nonprofit advocacy group collecting patient stories and the benefits of telehealth. You share this initiative with your entire group with contact information for the advocacy team. I'll leave these up here instead of stopping sharing so you can check out details. Any one of those feel better or worse for you? You can put it in the chat box if that feels better to you, if I can open it up.
Okay, I'm watching that too. Nothing so far.
Thank
Well,
you.
second feels better.
Lydia says second feels better. Right on.
Okay, I'd say second as well, so you're not really pressuring them to do anything one way or the other.
Yes. Yes, number 2 is much better. First could be coercive. Absolutely.
Yeah, as journalists, we're not supposed to pay for stories or compensate people. And the first one seems a little bit like that in terms of, providing this, it's almost like an in-kind benefit to the person for telling their story like that.
Yes, absolutely. Well said. The way I see number 1, a way that we could change it. So, for example, Derek and I both teach for Derek, I'm outing you. Both Derek and I teach for the addictions counseling program at the university. One way to change up number 1 could be I could ask if any of my, excuse me, patients are interested in sharing their story because it's a part of their recovery. I could say, hey, listen, I got a friend, colleague who teaches for the university. If that's really an important part of your recovery and you'd like to do that, I can ask him if there's a place in his, upcoming semester if he would like to have patient stories. That way he's getting to hear, somebody's shared experience in his class, and more importantly, his students get to hear from that, but it's a different dynamic because it wouldn't be my class they'd be coming to. And so they may feel less pressured to say yes to try to please me. By the way, Derek, that's something you and I should consider for the future. Any additional thoughts on that before we move over to our last topic, informed consent? Great thoughts and suggestions. Thank you. Let me look at the chat box. Okay. Jordan, I'm glad you're on here because this sort of just came up last week for us. So this just came up on one of our clinics recently, and so I thought it could be helpful to discuss here. Essentially, the question is whether we have the right to ask patients if we could check them out for signs of intravenous drug use. I'm actually going to just briefly review these aspects to consider here because I'd like to talk about them kind of in more detail when we go over the actual case. So I will say, for me, the way I'm sort of thinking it, this is really the second time the dilemma of privacy versus safety has come up today. It is an ethical code that patients have a right to privacy, and they absolutely have a right regarding what happens to their body during a medical appointment. And we also have the right to, we have the commitment to patient safety and keeping their physical health in mind when trying to make a decision regarding, prescribing certain medications. And so the question is, do you warn patients ahead of time that, quote unquote, arm checks may be a part of their medical appointment, is a part of your informed consent process in the same way that you inform them about drug screens, what that looks like. And then finally, how do you, I just want you to sort of keep this in mind, how do you balance the emotional welfare of the patient with their physical welfare? If you believe patients are using drugs intravenously and you're worried about their health, how do you present that to them in a non-accusatory way that isn't treating them like a quote unquote addict. And so here's the case example. So in a patient's chart, you see that they visited the ED last week for swollen hands and disclosed to the staff that they had been injecting their Suboxone medication. They then did not disclose this during their next clinic appointment. So a handful of questions I'd want you to think about. Would you inform them that you saw the note? And would that decision change if you were seeing them in a group setting versus an individual setting? Would you ask them to do an arms check? And then what about the rest of their body? Because we know folks can use drugs intravenously in other parts besides their arms. And then who would you ask to conduct the arms check? So because I'm throwing multiple questions at you, also, I won't stop sharing so you can, I'm gonna leave these questions up on the screen. And so I'd want to hear from you all. What are your thoughts on this?
I was going to say the one you brought up, kind of semi-brought up, again, it's the one we're involved with last week. But essentially the backstory was we're concerned with the patient using the Suboxone via IV use. And then, at least from my perspective, I think it'd be better to do it individually with the treatment team themselves to kind of say there's some concerns. Because what happened with us is essentially it came in for like a random UDS and medication count, and the MA kind of got thrown into it. So throwing a person they're maybe not as close to, I guess, for lack of a better word, into that situation, asking those questions.
Yeah.
But the MA we had actually handled it pretty well. I think the person actually thanked was wearing short sleeves, kind of like peripherally kind of looked at their arms and everything like that.
Yeah.
But yeah, to answer your question, I think doing it individually rather than group setting would be ideal. And
Yep.
then obviously having the treatment team that's involved in the patient's care being the ones to make that broach that subject versus someone they don't know as well, essentially, I guess.
Yep. Very much agree with that sort of individual perspective, particularly if it's something, you know, I think it's different if it's something that a patient has been open with all along in their treatment and in their group setting, and maybe even said, hey, this is a thing I'm trying to work on for myself. Would you guys mind hold me accountable and, you know, ask to see my arms from time to time? I think that's one thing versus if you've got that concern. Yeah, how can we address them in a way that this isn't a thing we're trying to catch you in? It's that we're worried about you and we want to talk with you about that. Any other, you know, Jordan brought up a great point of, you know, there's, I think, a lot of therapeutic reasons why it could be best to do this in an individual setting. One thing that becomes tricky in a group setting is based on what you have written in your informed consent to the patient. The question is, what kind of additional medical information can you disclose in a group setting that the patient hasn't brought up themselves first? You know, if a patient is bringing up, sometimes I'm shocked with the medical stuff that patients will bring up on themselves in a group setting, but more power to them. But if they're not bringing that up, you know, the fact that they were just in the ED, is it okay for us to bring that up? Is it okay for us to say, hey, I saw this in the note from this other provider. This is the thing that you said. I think that gets really sticky. So that is another reason I think to do it, and talk with them individually about it. See the chat box. No other chats. Any other?
I would just be obliged to talk to him because of the potential seriousness of a hand infection, the tendon involvements and things like that. So I would definitely broach the subject with him to make sure it's getting better.
Yes, yeah. And Dr. Corby, as you say that, what I do is hear your concern for the patient. I hear you say this has nothing to do about whether you're breaking our rules or not or anything like that, but I'm worried about you, worried about your health, and I just want to have an opportunity to properly treat you.
Yeah.
Yeah. Any other thoughts, suggestions, disagreements? Going once. Okay. I have showed this chart multiple times in past ethics presentations, so I'm not going to review it. Mostly, I just wanted you to have it in this most recent updated slide deck that you'll get emailed out tomorrow. It's just a reminder when we're faced with an ethical dilemma, we deserve to have the guidance of an ethical decision-making model, that we don't have to go through it all of ourselves. And this model is just an example of a couple of different ones out there that you can use. And then I almost always end my ethics slides with this slide. It's just a reminder as providers, we are going to make mistakes because we're human. As providers, our heartstrings are going to be pulled and we're going to want to help every single person we meet. Sometimes we have to accept that's not possible. We cannot know everything. We cannot expect ourselves to. That's why we continue our learning journey. That's why we come to this echo group. And that's why this echo group never says that's a silly question or dumb question or silly suggestion. It's all about great questions and great ideas. And as providers, we cannot and should not do this tough work alone. We need and deserve the support of our colleagues around us. And then just a couple ethics references at the end.
Great, thank you so much, Katie, as always, per usual. Sorry about all these technical issues. I even dropped out for a second there. It's been crazy. It could be on our end.
Yeah, no problem.
So I'll apologize. I don't think Mitra, yeah, she just texted me. She's just having a really hard time getting back in. So you were stuck with me.
No
But it was good to see everyone. Does anybody have any comments or questions following the didactic?
Thanks, Sheena.
All right, I gave it that echo pause. So the next time we're going to meet, it's going to be June 12th with Tony Dickiacchio doing West Virginia MAT program expansion and etc. So I hope to see you then and have a great rest of your evening.
Thanks, everybody.
Bye, everyone.